This session is about an unusual topic, not much talked about, but what I've attempted to do here is to summarize what's currently in the literature as well as what's currently in our research registry in terms of the vascular composite allografts, that would be face and hand transplantation. So here goes. Enjoy. The objectives for today's session include getting everybody on the same page in terms of recognizing that gender mismatch distress is something that is actually pretty predictable and shouldn't be seen as something unusual. Also looking at what are in fact the patient responses to gender mismatch in solid organ transplant, and looking at the potential consequences of having distress in these patients. And then also looking at team supports. What can transplant teams do both pre and post transplant in these situations? These two quotes here I thought really sum it up and are hugely valuable in terms of this topic. The first one, any change to the body is ultimately a change to oneself. And then the second one, we live through our bodies and not just in them. And I think if you can embrace both of these as a healthcare professional, then you will be able to move forward and embrace what we're going to be talking about today. These two concepts really set the stage, really lay the groundwork for where we're going with this material. Initially, you might ask yourself, well, this all seems interesting and exciting and certainly important, but important to people like psychiatrists, psychologists, and even social workers. And why would someone like a clinical ethicist or a medical ethicist care? Why would they be concerned about this topic? Why would it be relevant to them? Well, actually, it's very relevant to people who work in clinical ethics, especially in transplantation, because of these four concepts I've listed here: quality of life, informed consent, resource stewardship, and professionalism. These are key areas for the work of an ethicist. So the topic is very relevant to us, as well as the other folks I've mentioned in psychology, psychiatry, as well as social work. It's really important to start out in this topic with some foundational information pertaining to the clinical data of gender mismatch. So in terms of heart transplantation, the literature has shown us in the setting of pediatrics, there's no real issues coming about in terms of gender mismatch in the pediatric patient. We don't see any clinical issues coming about, and that's the most recent research coming from 2013. However, when looking at a registry study of 60,000 adults who had received heart transplants, men who received female hearts had a 10% increase in adjusted mortality relative to males receiving male hearts. So we did find that clinically there was actually an impact on mortality when there was a gender mismatch. With regard to kidney transplantation, there's also some interesting clinical data there, very similar, in that male patients who receive female kidneys also seem to be impacted. And you see there this first study of 6,800 transplant patients. They had the poorest graft survival when it was a situation of men receiving female kidneys. Similarly, the study here from 1999, they looked at 700 patients and male recipients of female kidneys were at a 5 to 8% increased risk of graft loss from rejection. And we'll talk a little bit more about this rejection issue down the track here in this presentation. Some of this, they speculate, is related to immunology, but there are potentially some other issues as well, and so we'll talk about that in a bit. Now, this is another area that a lot of people probably aren't aware of, but there is in fact gender mismatch cases in the setting of VCA. Again, VCA is our vascular composite allografts. So here we've got hand transplantation as well as leg transplantation. And you see in the top image there, we've got a man who has received a female hand. And the results you can see for yourself are actually quite good, both clinically and when you read the paper, psychologically for this patient. He's very, very happy with his transplant. And then in the lower image there, we see a leg transplantation, and this is a male patient who has received 2 female donor legs. And again, looking at that article, according to the authors, the patient is very satisfied with his transplantation. And it doesn't stop there. VCA, facial transplantation, while we haven't done any gender mismatch in the clinical setting yet, gender mismatch has been performed in the laboratory setting, proof of concept cadaver studies, both male to female and female to male. And you can see, at least in terms of technique, technology, it can be done, and the results look pretty good. But we certainly don't know what the results would be in terms of real life and the integration of this graft in a real life setting. That remains to be seen, but certainly people are moving along in this direction. So here then we have first introduced this concept and this notion of integration. What is it? Is the recipient integrating the graft, the actual donated item? Is the recipient integrating the donor, the person who donated the graft? What's actually being integrated, and is it the same for everybody? The answer, no, it's not. And this is what we have to recognize as members of transplant teams, especially when we're screening people to be recipients of transplants. So looking at the literature, we find that patients have essentially envisioned their grafts in 3 categories. The first one is a gift, and they see the item that they have received, whether it's a heart, liver, kidney, whatever, as a gift, and they've got a responsibility to it. Then there is the guest concept, and so the graft, the transplanted item, is something that's very foreign. It has intruded inside them. It's an invader. They're simply the host. And some of these people actually feel overwhelmed or taken over by a new identity. So the identity of the person or the personality comes upon them. They think of the donor who provided the graft. And then we have the spare part concept. And in this framework, the graft is neutral. So there's no personality. Everything is depersonalized. There's no DNA. And so these spare parts are more like just mechanical items. And the liver and the kidney, they're simply filters. The heart's a pump. The lung is a balloon. And the intestines, they're like pipes, etc., etc. And so you just kind of swap them out. When one breaks, you just put in another one. And it's, like I said, it's neutralized, depersonalized. That's very different than the first 2 items there, the gift and the guest. Very different. So when speaking to patients who are having distress, it's really important to understand how they are envisioning the graft that they've received or that they're about to receive. When patients get transplants, they can have lots of different responses to their graft. And like I said earlier, in terms of integration, no 2 patients are alike, and patients have unique experiences. And you can see here I've put in actual quotation examples from various articles that give ideas of how people actually respond. So you see the first one there, fantasization. I'll teach him how to ride a motorcycle. Personification. My new heart is a slave. Magical thinking. And now the lung is helping me with my troubles, etc., etc. And even down there at the bottom, psychosomatic illness. I guess you don't get someone else's heart without paying for it. Paying for it means having some sort of physical consequence. So I think this is very interesting and very much connected to the concept of organ integration, and very, very relevant to the topic of gender mismatch. So we briefly mentioned this notion of spare parts and the machine, so something breaks, you fix it, you take out the broken piece and you put something new in. But what's interesting is, even if transplant teams are using this terminology of the body as a machine and the spare parts and all that, patients may not be buying into that. Patients may still be having a connection to their donor, and that's what we as clinicians need to be fully aware of. So while we may be beating our drum and trying to keep everything neutral and calm with this machine spare part lens, patients can still be having distress and problems because of disruptions to their identity and the integration of grafts, and we need to be in tune with that. People need to be on the same page. So that begs the question, what should we be listening for from our patients pre and post transplant, so that we can get on the same page, so that we can be in tune to what they need, and respond appropriately. What in fact do we need to be listening for? Well, it's really interesting to note that conversations, it's not even pre-transplant and post-transplant, but there's interesting conversations that occur during transplant. And I've picked this one here, an actual intraoperative narrative. So this was a gentleman who was undergoing heart transplant, and the heart came from a woman. And during the operation, the surgical team kept referring to the donor heart in the terms of a female. But then when the chest closed and the heart was secured in the male body, the heart actually became male to the surgical team. And they then in turn started referring to the heart in male terms, using male pronouns. So that's some of the clinical narratives from the team. And going forward, we'll talk a little bit about patients and what are their narratives. In the pre-transplant setting, there's a study here from the Journal of Heart Transplantation, and 31% of patients waiting for a heart had fears about new heart changing their personality. So this is a great place to start. And you'll actually see a trend emerging in these next few slides. So switching now to post-transplant narratives, here's an example. Both of these studies here are recent studies, one from 2014, one from 2013. The first one here, we have a woman in her late 50s. She received a male donor heart, and having this male donor heart inside her, she no longer had affectionate feelings toward her husband, and didn't want to even have sex with them anymore. So you got to wonder what was going on with that. Did she feel like part of her was now male, so she couldn't have an affectionate relationship with another male? And hold on to that thought, because we're gonna pick that up in another context shortly. But with this next one here, we had a post-menopausal woman, and she got a male donor kidney, and interestingly, she thought that kind of gave her more sexual power. She thought that she was getting hormones somehow from his kidney, she thought that she kind of became this new sexual powerhouse. So went the other direction in that regard. Some more post-transplant narratives here. A 42-year-old fireman received a female heart, and he was very upset because he thought that that would impact his masculinity. He might become impotent, and he worried that his peers, his fellow firefighters, would not accept him anymore because he got a woman's heart. Same sort of thing going on here. Another study from 2005, males who received hearts as well as kidneys. 50% of those said, first of all, that they wanted to receive an organ that was matched to them by gender, and they also were concerned about if they got a mismatch, that would somehow make them more feminine, and that was something they obviously did not want. And again, this reoccurring theme, another study, 29% of men stated they did not want to have a female heart. And again, they were concerned about these issues of their identity, as well as even incompatibility. But you can see a strong trend here with men receiving female organs. It can be quite distressing. So here's another example, same sort of concept happening here. Men being very concerned about their masculinity in the setting of having received female donor hearts, and you can see, well, if that's the case, I'll have to go out chasing men from now on, wouldn't I? Etc. Etc. You're not saying that I'm gay now, are you? I haven't turned lesbian, have I? So with all of these quotes, and including the previous ones that we've seen here, there's a strong theme that's emerged that men can be very concerned about their sexuality and their identity if they are or have received a woman's graft. So that very much needs to be on our radar. We can't sit back and say no, that these types of problems and distress really doesn't happen, because yes, in fact it does, and we have to be prepared to address it. It's interesting that when looking at the literature, the medical literature that is, there are so many narratives about the heart, and I think part of this is because the heart is so vividly portrayed in medical history, literature, film, art, religion, spirituality. There are so many facets of the heart. So whether you want to think of the heart as a pump, that's one thing, that's the most very basic, but the heart can also be the center of one's vitality, and that's why we have the term brave heart, the center of emotions, where the soul is held, a place of physical pain, a physical place itself. It's certainly something of value. That's why we have this phrase, heart of gold, and also the container. So you filled my heart, whatever you're going to fill it with, joy, pain, whatever. So it's fascinating that the heart keeps coming up in transplantation in this setting here that we're talking about emotionally and psychologically, more than other organs. We don't see these narrative discussions appearing with regard to lung and this and that, and maybe that's just perhaps because it hasn't been studied, or maybe it doesn't exist to the extent that it does with the heart. Who knows? But this is what we're finding right now. And certainly if we take a look at the heart in various languages and culture, you find that it is a powerhouse compared to other internal organs of the body. So you take a look here, we've got Chinese culture and Chinese medicine. the heart is actually the master. It's the controller, the monarch of the body, and it's the center house of intellectual and emotional activity. That's pretty heavy. It's not the intestine, it's not the lung, it's not another organ. It's the heart. Same thing for Japanese culture and language. That's where thoughts and emotions start. That's where they arise from. And then we've got the Korean culture and language. That's where even your memories are stored. So the heart, like I said, is quite the powerhouse. So it's not really surprising that we're seeing distress signals come from transplantation involving the heart as compared to other organs. Now, in the setting of hands and hand transplantation, just a quick reminder that hands, they do many things. We don't think about it necessarily every day because we're using them, but if you sit down and you itemize how many different things the hands do, it's pretty amazing. But certainly one thing they do is give someone their identity. You can look at a hand, whether it's the palmar surface or the top surface of a hand, and often you can recognize someone just by the structure and the visual appearance of the hand. So when you talk about doing a gender mismatch hand transplant, that is a big deal because unlike a kidney transplant or a heart transplant where you do the transplantation and you never see the internal organ, it's sewn up inside, something like a hand transplant, totally visible, not only to the patient but to the world. Similar sort of discussion arises with the face. So again, face 100% visible if you're doing a face transplant. Everybody's going to see it. The face certainly gives identity. The structure of someone's nose, the color of someone's eyes, how someone parts their hair, the smile or lack of smile, and certainly, for better or worse, probably for worse, people can be judged purely on their facial appearance. So the concept of doing gender mismatch in the setting of face transplantation, we have to be really, really careful where we might be going with that. We have to be very prepared for screening these recipients and then dealing with any potential aftermath of distress in terms of mismatch. Similar discussion with leg transplantation. You saw the picture early on, and that patient says he is very happy with the leg transplantation he receiving the women's legs. But again, legs do many things. We don't often think about it because we're mobile and we use them and that's it. But certainly they're part of our posture. And generally in society, it's the tall people with beautiful, robust legs that look good. They are the people who are prized, and legs themselves can give identity. So again, we've got to be very, very aware of what we're doing if we're going to be going down a path of gender mismatch in terms of leg transplantation. So the concept of organ integration is 100% linked to concepts of identity and personality. And we've got to keep that in mind as clinical folks. And whether you're talking about solid organs, especially the heart, or visible VCA such as hand, limb, and face, it can't just be the organ's going to be integrated and the patient's going to take their medication and we're not going to have issues with compliance and et cetera, et cetera. It's much bigger than that, and that's what this talk is focusing on. So now we're coming into the meat of what clinicians need to know and how this is really practical to their work in transplantation and screening folks So, getting down to the nitty-gritty here, why are these psychological concerns important? Well, one of the reasons is that people who are on the waiting list could actually decline graft offers that are gender mismatch, if they feel that they just can't tolerate it. And if that's true, and if they can't tolerate it, and that's insurmountable, then it's the right thing to do to decline that graft offer. And we'll talk about why in a moment. But basically, every time someone declines a graft offer, that means they continue to sit on the waiting list. And continuing to sit on the waiting list means that potentially they're going to get sicker, and their quality of life is going to get worse. Their healthcare costs are going to increase, and you also run the risk of being eventually too sick to be transplanted, and then you've got to be removed from the waiting list. Because you could wait forever, and maybe there will be no proper gender match for you, and your number essentially won't come up, and you're so sick anyway you couldn't even get a transplant. So that's something that's got to be made known to people in advance that are thinking about potentially not taking an offer. The other big issue that we have here is if we deny the problem exists, we as clinicians or patients, if patients deny their distress and just go with it, we tend to see the problems with poor coping skills. And those people then are at an increased risk of not adhering to the various regimens that need to be adhered to post-transplant. So those are things like medications, biopsies, clinic visits, etc., etc. But also have potentially psychosomatic problems and ultimately graft failure. So yet the other thing here is you can see the study from 2010, Heart and Lungs. They found that most deaths and graft failures were in people who were in denial. So they had psychological issues, but were just in denial about it and didn't get proper remediation to pull them out of that, and it just put them into a downward spiral. And something else too that we can't forget is that patients in these situations can easily be classed as difficult, and I don't think that's unfair. I think that's probably an appropriate classification. They are difficult to work with in this sort of setting, and difficult patients are very taxing emotionally for transplant teams. It takes a lot out of you to deal with these types of situations. So if you can prevent them, that is really the best thing. So a proactive approach would be optimal. So this then begs the question, where are we as clinicians failing? Are we doing some of this perhaps to ourselves, and then we find ourselves in bad situations? And the answer is yes. Literature tells us that often we simply do not, acknowledge the existence of gender mismatch distress. We just plow along with our mechanical spare parts concepts when we talk to patients. And in doing so, we are not preparing them for potential distress that they may encounter. And that's not good for them, and it's also not good for us. So ways to turn that around are certainly to recognize that this concept, gender mismatch distress, it's real. It does happen. It's gonna happen, and don't see it as something as abnormal, but in fact be ready for it. That actually needs to be part of our mindset when we're screening patients for transplantation. We need to be ready to respond when patients talk to us about this concept pre-transplantation, and certainly when it arises post-transplantation. And in the pre-transplant setting, this sort of discussion, this sort of material needs to be built into the informed consent process. and I would strongly, strongly suggest that you actually formally include this in your consent form. So in your consent document, that you have some text there that discusses this concept. Just put it out on the table. There's no sense in hiding it or not talking about it, because it does exist, and when we hide it and we don't talk about it, it tends to be more problematic. The other things that we need to do is we really need to move away from this notion of the machine spare part lens or framework. It doesn't work. I think we assume that it serves a great purpose, but I think we are kidding ourselves, and we need to go back and just knuckle down and talk to our patients about the humanness of transplantation and really make it what it is. It is a human endeavor, and so be it. And the other piece of that is always keeping transplantation as the big picture sphere. And what I mean by that is it's not just organ transplant. You don't just put the organ in, take your meds, and walk away. But everybody needs to be of the philosophy and embracing the idea that it doesn't just stop at transplant. The other piece of it is organ integration. That's got to be part of the process. And certainly there are tools that we can have at the ready, both pre and post transplantation, to help our patients. Clinical ethics consultation should always be available by a professional clinical ethicist. Most transplant teams do have a transplant ethicist on board, and that's great. So please use them. Please reach out to them for these situations. Certainly psychological consultation. Again, transplant teams generally always have either a psychologist or a psychiatrist on board, and they need to be totally geared up for this issue of gender mismatch distress. And the other thing is to having at the ready good solid mentoring from post-transplant patients. Studies show that patients who are either candidates for transplantation or transplant patients themselves like mentoring from people who also have had transplantation, because they feel like it makes it real. Lastly, I just want to close by bringing everybody back to really where we started and reminding us all of this foundation. Any change to the body is ultimately a change to oneself. Again, no spare parts, and we live through our bodies and not just in them. Thanks very much. If you'd like more information about transplant ethics consultation, or other general topics related to organ donation, check out my websites. Thank you.